So, our mission today is, well, it's to untangle this massive and honestly pretty dangerous misconception in maternal mental health.
Hmm.
And we are pulling from the clinical insights of coping and healing counseling, which is a telehealth practice based out in Georgia.
Right.
Because, when we usually talk about childbirth in our culture, we're handed this incredibly pervasive kind of hallmark card script,
Oh, absolutely.
like the soft lighting, the peaceful exhaustion, that instant sort of magical bonding moment when the baby is finally, placed on your chest.
Right. The narrative is it's almost completely sanitized.
Yeah.
We
Yeah.
we frame it entirely as this beautiful natural transition,
Hmm.
the ultimate joyous occasion.
Yeah.
And that sets up an incredibly rigid expectation for new parents.
It really does. But the materials we have from coping and healing counseling, they highlight a reality that just shatters that script entirely.
It totally shatters it.
We're looking at how postpartum depression and postpartum PTSD are almost always linked together out in the world, like as if they're the exact same condition. Right. And they are absolutely not. So, okay, let's unpack this. Because a difficult birth, it can leave a profound trauma response, right? Not just a low mood, and it's something that simply does not get said enough.
No, it really doesn't. And the clinical data backs that up entirely.
Hmm.
I mean, they have completely different origins, different manifestations in the body, and they require entirely different approaches to healing.
Right.
When society lumps a trauma response under the umbrella of just, depression, we are doing a massive disservice to parents who are suffering. We're essentially misdiagnosing their reality.
Exactly. So to really understand how to help someone, we first have to understand where the specific trauma actually originates. It
Yeah.
doesn't just appear out of nowhere, because hormones shifted or just because of sleep deprivation. It has a specific flashpoint.
Right. When we look at PTSD after birth, it almost always traces back to a very tangible event.
Like a specific moment.
Exactly. Something that happened in the delivery room or the immediate aftermath. It is rooted in an experience of profound threat or helplessness.
Wow.
And the materials from coping and healing counseling outline exactly what these flashpoints look like.
Mm.
We're talking about severe, unexpected medical interventions.
Like what kind of interventions?
Well, for instance, an emergency transfer to a hospital from a home birth or birthing center,
Oh, right.
where suddenly, the entire atmosphere shifts from calm to frantic and time is of the essence.
It's that sudden violent shift from like everything is fine to this is an absolute life or death emergency.
Right. Or consider a massive hemorrhage, where there's a sudden, terrifying loss of blood and the room instantly fills with medical staff shouting orders.
God, that sounds terrifying.
It is. Or a den ICU stay, where your newborn is whisked away, put behind glass, hooked up to machines.
Yeah,
And the parent is left completely powerless to comfort them.
that's devastating.
But one of the most insidious flashpoints they note, and this is so crucial for understanding the psychology of trauma, is the impact of medical invalidation.
Invalidation, meaning like how the person was spoken to in that moment of crisis.
Exactly. The source material specifically highlights the trauma of, quote, being told to calm down while you knew something was wrong.
Wow.
It's that profound disconnect between a mother's instinctual realization that her body or her baby is in danger and the medical staff dismissing or minimizing that reality.
Right. Well, let me push back on that a little bit, actually,
Sure.
because I think a lot of people might hear that and want to defend the medical staff. I mean, a delivery room in an emergency is inherently chaotic.
It is, yeah.
Aren't the doctors and nurses just, trying to save lives? Like, is bedside manner really a primary concern when someone is actively hemorrhaging or a baby is in distress?
Look, it's a critical point to raise, and of course, physical survival is the ultimate priority of the medical team.
Absolutely.
But psychological safety is what dictates the long-term trauma response.
Oh, I see.
To understand the mechanism here, we have to look at how the human brain processes threat. During a medical crisis, the patient is incredibly vulnerable.
Yeah, they're relying entirely on the experts in the room.
Exactly.
Right.
When a patient says, something is wrong, I can't breathe, or, the pain just changed, and the expert responds with, you're fine, just calm down.
Hmm.
The patient's brain experiences a secondary trauma. It isn't just that their body is failing, it's that the people who are supposed to save them are ignoring the failure.
They're being abandoned.
Yes, the brain codes that isolation as a profound, life-threatening abandonment.
That makes total sense. It amplifies the helplessness. I think of a very specific analogy here. Like, imagine you survive a terrifying high-speed car accident.
Okay, yeah.
The car is completely totaled. You are pulled from the wreckage by emergency responders. If someone survives that crash, we do not follow up with them a month later and just ask if they're in a low mood.
Right, we don't.
We recognize they survived a massive physical and psychological trauma. We ask about flashbacks. We ask about anxiety when getting back into a car.
Yeah.
So why on earth do we treat a medical emergency in a delivery room where you are literally facing your own mortality differently than we treat other physical traumas?
Well, what's fascinating here is how societal conditioning completely overrides clinical reality when it comes to mothers.
Oh, say more about that.
Society is so intensely focused on the mood of the new parent. We have this culturally acceptable box called postpartum depression.
Right.
So when a parent is struggling, society looks at them and says, she's sad, she's tearful, she's struggling to bond. It's the baby blues, it's postpartum depression.
Just putting it all in that one box.
Exactly. They are completely missing the intense trauma response that was triggered by the terrifying events in that hospital room.
Wow.
We pathologize the sadness, but we completely ignore the terror.
We ignore the terror. And
Yeah.
man, if we ignore the terror, we are completely misinterpreting the symptoms. Which brings us to what this actually looks like as time goes on. Because knowing that the trauma starts in a moment of sheer terror, well, it perfectly explains how it manifests so differently than typical depression months down the line.
Right. The long-term presentation is where the distinction becomes undeniable. And honestly, where misdiagnosis becomes really dangerous.
Yeah.
The clinical materials we're reviewing, they break down the specific realities of someone living with postpartum PTSD, looking at a time frame like 6 months out.
Okay, so half a year later.
Yeah, and the symptoms are structural trauma symptoms. The first major one is intrusion.
Okay, and intrusion isn't just like sitting on the couch and remembering that the birth was difficult, right?
Far from it. Intrusion means the delivery is replaying in their head without warning.
Just randomly.
It is a visceral flashback where the brain and body feel like they are right back in that hospital room. The nervous system releases the same flood of adrenaline and cortisol.
Oh my gosh.
They might literally smell the iodine from the operating room or hear the specific tone of the fetal heart monitor alarms completely unprompted while they're just, standing in their kitchen.
The trauma is literally intruding on their present reality.
Exactly.
And naturally, if your brain is constantly forcing you to relive the worst day of your life, you are going to do everything in your power to avoid anything that triggers it.
Which leads directly to the second major symptom, which is avoidance.
Okay.
The source material gives a highly practical example of this. The OB follow-up appointment gets canceled and then canceled again.
Oh, because they can't go back.
The person cannot bring themselves to walk back into a medical setting.
Yeah.
They might avoid the doctor who was there. They might take a longer route to the grocery store just to avoid driving past the hospital.
Because if the hospital is the site of the car crash, you avoid the intersection.
Exactly. You avoid it at all costs.
But it's the third symptom the materials mention that really caught my eye, which is hypervigilance. So the specific example given is that the parent will not let themselves sleep because they are actively listening for the baby to breathe. Now, wait, isn't listening for the baby to breathe just a universal, normal new parent anxiety?
A lot of people ask that.
Every parent I know has stood over a bassinet at 2 a.m, staring in the dark, watching for the baby's chest to rise and fall.
Oh, absolutely. Distinguishing between normal evolutionary parent anxiety and clinical hypervigilance is the key to understanding postpartum PTSD.
Okay, so what's the difference?
Checking on a newborn is absolutely a universal experience. But let's clarify the mechanism using the framing from our sources. It becomes PTSD when the parent will not let themselves sleep to do it.
Oh.
We are not talking about waking up, checking the monitor, feeling reassured, and going back to sleep.
Right.
We are talking about living in a constant, unrelenting state of threat.
It's the complete inability to accept reassurance.
Yes,
Yeah.
and to take that a step further, it is a biological survival mechanism gone into overdrive.
Like their brain is stuck.
The amygdala, the brain's threat detection center, it has learned from that traumatic birth that disaster strikes without warning,
Oh, wow.
and that the medical professionals cannot necessarily be trusted to keep them or the baby safe.
Because of the invalidation we talked about earlier?
Precisely. Therefore, the parent's nervous system concludes, I am the only thing keeping this baby alive, and if I close my eyes, my baby will die.
God, that is heavy.
So they stay awake, For
Yeah.
days, for
Yeah.
weeks, they are functionally operating in a war zone.
That's unbelievable. I mean, if the brain's alarm system is fundamentally broken like that, telling a parent to, try to rest when the baby rests or take a bubble bath, it isn't just unhelpful. It's physically useless.
It's the equivalent of offering a Band-Aid for a broken bone.
Yeah.
Because these symptoms, the intrusive flashbacks, the severe avoidance, the extreme sleep deprivation fueled by terror, they're entirely different mechanisms than the low mood or lethargy or apathy we see in general postpartum depression.
It's like trying to fix a hardware issue with a software patch.
That's a great way to put it.
Telling a traumatized parent to take some time for yourself is a software patch for depression. But PTSD is a hardware alarm system that will not turn off. You
Exactly.
need a clinician who knows how to get into the motherboard and reset it.
Yes.
So how do clinicians actually shut that alarm off? Like, what do they actually do?
Well, the materials from coping and healing counseling explicitly name two treatments that have real empirical research behind them.
Okay, what are they?
Trauma-focused CBT, which is cognitive behavioral therapy, and EMDR.
Okay.
But before those are even applied, if we connect this to the bigger picture, the source emphasizes the vital role of the licensed therapist. They list clinical social workers, professional counselors, and marriage and family therapists.
Right.
Their job isn't just to provide a sympathetic ear. Their job, as stated in the text, is to sort out what is actually happening.
So they're diagnosticians first.
Absolutely.
They have to look at the symptoms and figure out if they're dealing with a software bug or a hardware failure, like a specialist mechanic. You don't just ignore a rattling engine or white-knuckle the steering wheel. You take it to someone trained to diagnose the exact broken part.
Yes, and once they identify that it's a post-traumatic stress response, they can apply the targeted therapy.
So how do those work, the CBT and EMDR?
Let's look at the mechanisms. Trauma-focused CBT works by identifying and restructuring the specific cognitive distortions that the trauma left behind.
Like what we said before.
Exactly. For example, that deeply held belief we just talked about. If I go to sleep, the baby will die.
Right.
A trauma-informed therapist helps the parent systematically dismantle that belief. They examine the evidence, and they rewire the thought process so the brain stops perceiving sleep as a mortal threat.
That makes a lot of sense. And what about EMDR? Because I think a lot of people have heard that acronym, eye movement desensitization and reprocessing.
Yes, EMDR.
But the actual mechanism sounds almost like magic if you don't understand it. Like, how does moving your eyes actually fix a trauma response?
It sounds unusual, I know, but it is grounded in neurobiology.
Oh, really?
Yes. When a severe trauma happens, the memory often gets stuck in the emotional fight or flight side of the brain.
Okay.
It doesn't get filed away into long-term storage like a normal memory.
Yeah.
That's why flashbacks feel like they are happening right now.
Because to the brain, they are.
Exactly.
Yeah.
So EMDR uses bilateral stimulation, often having the patient track the therapist's fingers back and forth with their eyes while they briefly focus on the traumatic memory.
Just going back and forth.
Yes. And this bilateral movement mimics what happens during REM sleep.
Oh, wow.
It essentially keeps the brain grounded in the present, safe moment while forcing the two hemispheres of the brain to communicate and finally process that stuck memory, moving it into long-term storage.
That is wild. So the memory loses its intense physical, emotional charge. Like, you still remember the birth was hard, but your body stops reacting as if you are currently hemorrhaging in the delivery room.
Precisely. You have the memory, but not the physical terror.
Here's where it gets really interesting, though. Because the source material from coping and healing counseling, it follows up these clinical descriptions with this incredibly powerful mandate. It just states plainly, nobody has to white-knuckle this.
It is a profound phrase.
Yeah.
It speaks directly to the isolation so many parents feel. They assume this constant state of dread, this inability to sleep, is just the new price of admission for parenthood.
Because everyone just calls it the baby blues.
Right. So they grip the steering wheel, they suffer in silence, and they try to just survive each day.
But here is the massive paradox we have to address. Let's say a parent realizes they shouldn't be white-knuckling it.
Okay.
They understand they're dealing with trauma, and they know they need EMDR or trauma-focused CBT. How on earth does a parent with a 6-month-old actually do intensive trauma therapy? I mean, we're talking about sleep-deprived, hypervigilant parents who are terrified to leave their baby's side.
It's a huge issue.
Expecting them to, pack up a diaper bag, fight through traffic, and sit in a sterile clinic waiting room. potentially a medical setting that actively triggers their trauma. I mean, that just feels like a complete setup for failure. The logistics seem literally impossible.
Access is historically the greatest barrier in maternal mental health care.
I bet.
You have a population that is largely homebound, physically recovering from birth, and tethered to the unpredictable feeding and sleeping schedule of a newborn.
Right.
The traditional clinical model demands that the patient adapts to the clinic.
Which just doesn't work here. Which is why the model outlined by coping and healing counseling feels so vital to this conversation.
It really is.
They are actively dismantling those logistical barriers. The materials note that they operate as a 100% high PA compliant telehealth practice, serving all 159 counties in Georgia.
Right.
So right away, the commute is eliminated. You don't have to drive anywhere. You can access a culturally competent, diverse team of over 15 licensed therapists from the safety of your own living room.
Eliminating the commute is a massive structural shift.
Yeah.
But the secondary barrier is almost always financial. Specialized trauma therapy is notoriously expensive and often out of network.
Oh, absolutely.
But coping and healing counseling has structured their practice to tackle this head-on. For patients on Medicaid, they offer a $0 copay.
Wait, a $0 copay for specialized trauma therapy?
Yes, $0.
That is practically unheard of. I mean, free specialized therapy.
It is a game changer for accessibility.
Yeah.
And for those with commercial plans, they list major providers like Aetna, Cigna, Blue Cross Blue Shield, United Healthcare, and Humana.
Okay, so pretty much all the big ones.
Right. For those, the out-of-pocket cost typically lands around $10 to $40 a session.
Wow.
They are intentionally removing the financial friction that keeps traumatized parents from getting help.
Okay, so the commute is gone, the financial barrier is dramatically lowered. But that still leaves the biggest hurdle, the baby.
Right, the baby.
Because the hypervigilance symptom we discussed means these parents often do not trust anyone else to watch their child, not even for an hour.
Exactly.
And the source materials note a very specific approach they take regarding this. They mention that they see adults by video, quote, newborn on the lap and all.
It is easily the most impactful detail in their entire clinical approach.
Really?
Oh, without a doubt, it changes the entire paradigm of mental health care for parents. By embracing the reality of the patient's life, the barrier of childcare is entirely removed.
Because you don't need a sitter.
No sitter. The therapist is essentially saying, come exactly as you are in whatever state of chaos your living room is in.
I love that.
Hold your baby.
Yeah.
Feed your baby. We will do the clinical trauma work right here, together, while you are fulfilling your role as a parent.
It just validates the parent situation instantly.
It really does.
It proves to them that their role as a mother or father and their desperate need as a patient, they do not have to be at odds with each other.
No, they don't.
You don't have to somehow pause being a parent in order to heal as a trauma survivor. You can do both. Sitting on your own couch, with your baby safe, right there in your arms.
Yes.
Which immediately de-escalates that hypervigilant alarm system because the baby is right there.
Exactly. The baby is safe, the parent is safe, and the healing can actually begin.
Man, so what does this all mean? We started by talking about that Hallmark card expectation of birth and how the brutal reality of a medical emergency can completely shatter that, leaving a very murky, misunderstood diagnostic landscape behind. Society is so quick to label any postpartum struggle as depression, completely missing the fact that a massive percentage of these parents are surviving a post-traumatic stress response.
Right.
But through the resources of coping and healing counseling, the mechanics of that landscape actually become very clear.
They do.
If you are listening to this and you have a loved one, a sister, a friend, a partner, who is 6 months out from a harrowing birth experience, and they are still living in that trauma, if they are still canceling their follow-up appointments, still refusing to sleep because the alarm bells in their nervous system just won't stop ringing, tell them about this distinction.
Please do.
Tell them they might not just be depressed. They might be dealing with a hardware issue, a structural trauma response, and most importantly, let them know there are licensed professionals who know exactly how to reset that alarm system entirely through telehealth with the newborn right on their lap. Like we said, nobody has to white-knuckle this.
This exploration raises an incredibly important question for the future of maternal care, doesn't it?
Oh, how so?
Well, if we look back at the root causes we discussed, and we fully acknowledge the clinical reality that medical invalidation, specifically being told to calm down when you knew something was wrong,
Yeah.
if that is a direct root cause of clinical PTSD, How might that fundamentally force hospitals and OBGYNs to change the way they communicate with mothers in the delivery room?
Oh, wow. I hadn't thought about that.
We spend so much energy treating trauma after it happens.
Right.
But if ignoring a mother's voice is the trigger that breaks the nervous system, could changing the basic bedside manner actually be a preventative measure for PTSD?
A completely different kind of preventative medicine. Not a pill, not an intervention, but a profound shift in how the medical system listens to women.
Exactly.
It really makes you wonder how many trauma responses, how many months of hypervigilance and flashbacks could be avoided entirely if the very first response in that delivery room was simply, I hear you, I believe you, and we are going to fix this together.
It's a powerful thought.
It really is. That is definitely something to think about.